No, I got to tell you, this is one of the best meetings that I've been to. I've looked at the agenda on this, and I speak, for a reasonable number of times a year, and I'm trying to scale back because of my kids and my wife at home. But I will tell you that the turnout. That's right. They all got 10 pieces of Halloween candy and donated the rest. But anyways, no, I'm really impressed by, I thought this was going to be predominantly just a prostate cancer meeting, which for me starts to get a little bit dry. But I was really impressed by what was put together and certainly some of the questions that have come forward. So I was asked to speak about urinary and sexual health. This is a big part of what I actually do in practice, okay? And so how we work together, meaning when I say we, I mean those of you that treat prostate cancer and those of us that try to focus on some of the things that go along with that, okay? And I'll talk more about survivorship later in the course of this meeting. So in 20 minutes, I'm going to go on the data as it relates to urinary control following surgery and following radiation, discuss the outcomes of anti-incontinence surgery and the impact of radiation therapy, define penile rehab to an extent if possible, and to discuss the current state of the art of penile rehabilitation after radical prostatectomy and the evidence or lack thereof for different strategies. Okay? So, audience response question. Accessory pudendal arteries are the major inflow to the penis in approximately what percentage of men? 10, 30, 50, 70, or 90? Okay, number one answer was B, 30%. Which of the following agents used in penile rehabilitation causes intracavernosal fibrosis? Papaverine, phentolamine, atropine, alprostadil, or vardenafil? Okay, well, the highest answer was papaverine, but there's answers across the board. So, post-prostatectomy incontinence, okay? So published studies on the risk mostly involve retrospective data, and there's variable definitions as to what constitutes continence, right? And typically doesn't involve urodynamics data, but that's for good reason. We talked about that earlier today. Reported rates vary from less than 10 to as high as 80, but about 20% use pads after surgery in the long term, okay? There's no significant difference between open and robotic in a prospective trial, and that was there was a meta-analysis of retrospective studies suggesting a benefit with robotic approach. I do think that we see less men for severe incontinence in the robotic era. I do believe that. But, I just want you to know that when I see these men in practice, I never refer to this as a complication of radical prostatectomy. If you do the operation the same way every time, different patients heal differently. Okay? And it's all on a spectrum. Same thing with their sexual function. So there was a prostate cancer outcome study, nearly 1,300 men after surgery. At 18 months follow-up, 8.4% were incontinent, but only 31.9% had total urinary control. So you can see how the definitions can, change the numbers. Similarly, 65% had self-reported incontinence in another study. So what are the trends in repair? Well, we looked at this nationally, okay? 32,000 procedures for male incontinence were performed over 12 years, 20,000 artificial sphincters, 11,000 slings, and there was a significant decrease in the total number of procedures done. So less men are getting surgery for incontinence, despite a relatively stable rate of radical prostatectomy during that time span. But when stratifying data by the type of the anti-incontinence surgery, sphincters were going significantly down and slings were going significantly up. Now, does this say for certain that we're seeing lesser degrees? Not for certain. There are other things that could be possible. So it could be that the sling is patient-driven. We already know that given the option, patients like the idea of a sling better than a sphincter because they don't have to cycle a device. It could also be that surgeons are becoming more comfortable doing slings and using them to a greater degree to treat higher levels of stress incontinence, and they may be becoming more risk-averse to doing a sphincter. What's the impact of radiation? Well, 1 in 3 patients will require adjuvant or salvage radiation at some point after surgery. Adjuvant IMRT has been shown to have late incontinence rate of 18% and a stricture rate of 6%. Adjuvant radiation has more than 2 times worse incontinence than a wait-and-see approach. That was based on the SWOG study. So it's important to consider when long-term follow-up of an EORTC trial has shown that clinical progression-free survival, previously reported with adjuvant radiation, no longer significant. So in patients over 70, adjuvant radiation had detrimental effect on progression-free survival and overall survival. Continence may improve for 1 to 2 years after surgery, which blurs the data on the overall impact of radiation, and there's also the issue of pathologic continence. What do I mean by pathologic continence? So if any of you have ever worked in the VA, you might be taking a guy for a penile implant. Maybe you're a resident. And at the beginning of the case, you go to place a catheter, and you can't get it in because they had a contracture you didn't know about, right? And so maybe you thought, maybe it's okay, I'll just dilate the contracture and go ahead with the operation so I can have a catheter for safety. And then when the guy has a catheter taken out, he starts to leak, and he's wondering what you did to him. So that's what I refer to as pathologic continence. Timing, less than 6 months or greater 6 months, how far out you are from the radiation doesn't seem to make a significant difference based on retrospective data in terms of the outcomes from anti-incontinence surgery. So a meta-analysis looking at complications after sphincters in patients that had had both surgery and radiation saw that the revision rate is significantly higher if they get radiation, and persistent incontinence is significantly higher. So it's not the best thing for optimal outcomes. Doesn't mean it's not worth doing a sphincter, but they're not going to do as well as if they never had radiation. The risk of erosion is higher, and the overall success rate with AUS does drop in irradiated patients, looking at 89% if they're not haven't been irradiated to 56%. So what about slings? Some people say you should never put a sling in a radiated patient. I wouldn't say never, right? One of the words you learn to not use, never and always. But Advent sling success is about 54% overall in the radiated patients versus 75% if you include radiated and non-irradiated. So there's an ongoing trial called the MASTER trial, and that data will be available eventually. And this is being done in the UK. And so they're comparing the sling versus the sphincter, multi-center after prostate cancer surgery, or after prostate surgery, whether cancer or benign. Any age, any level of incontinence, no exclusion for radiation, and they want to randomize 360 and follow another 360, but it's only slated for 2-year follow-up. So what about ED? So ED after radical prostatectomy is high as 90% in some series, but more recent data suggests it's probably around 68%. Still the most common long-term side effect after radical prostatectomy. I don't think that this necessarily should be attributed to the surgery in all cases. I find that a lot of men don't have a pre-existing diagnosis of ED on their record because it hasn't gotten bad enough to seek treatment, or nobody asked them. They got diagnosed with prostate cancer, they come back, and now people are asking, what about your erections? Well, they probably had some degree of ED already based on what we know about statistics, and I told you those earlier from the aging studies done in Massachusetts. But we will see those patients. You mentioned support groups being a problem, and I agree. I think physicians should oversee a lot of these man-to-man or us-two groups. I think if you're going to have a chapter locally, be involved. Have yourself there or a representative there. But you will see these men that say they wish they never had their prostate surgery. Data shows that men are actually willing to accept a 10% decrease in overall survival to preserve their erectile function when considering their treatment options. Okay, so it's important. Dry and potent patients rarely have regret from having their prostates out. Okay. Preop counseling for the vacuum device for intracavernosal injection has demonstrated reduced long-term post-op regret by a factor of 10. So the impact of sexual function appears to be greater than that of incontinence. That surprises me, but I think it's probably relative to the degree of either condition, tell you the truth. But it does negatively impact quality of life. And you'll see those couples, if you're someone that treats ED in your practice, and you'll see the wife pat his hand, it's okay, we have a good relationship, but intimacy is always important. Now, you don't necessarily need intercourse to have intimacy, but there's something unique about that type of behavior, okay? And I already told you that there's always a psychological component, even if it's organic ED from something else. So if you have access to a good counselor, that should be part of your survivorship program. And again, we'll talk about that tomorrow. Like I tell patients when we're talking about nerve input and vascular input, it's all plumbing and electricity. I try to keep it simple to explain how this works, right? So what about the plumbing, the arterial protection? So there are accessory pudendal arteries above the pelvic diaphragm that are prone to injury during radical prostatectomy. These are the major inflow to the penis in 70% of cases and the sole inflow in 10. Some suggestion of improved erectile function if you're able to preserve these, okay? Major inflow in 70%. What about the electrical input, the cavernous nerves? Well, it's a poorly visualized plexus and it's quite variable. It can be injured by a number of ways, traction, transection, thermal. And so neural injury leads to fibrosis via TGF-beta1 and pro-apoptotic factors. Absence of nocturnal tumescence may contribute to hypoxic injury. Use it or lose it, right? So we talk about not having those frequent unconscious erections. What does that mean for patients? So offering penile rehabilitation, it may seem like a no-brainer, but it's not free. It's not always convenient, and there are side effects. And we need to address both form, physically, and function. So what is penile rehabilitation? Well, is it just enabling sexual function after treatment for prostate cancer? Is it restoring their natural and spontaneous erections? Is it getting them back to their pre-op status? We don't know because it's not well defined, okay? To say rehab, the concept would be it will get you back to where you were. But that's a moving target because we know that every day that goes by, that man's a day older. His body's a day different. It's a different environment, okay? So if you had never operated on him and followed him for the same length of time, his erectile function would be worse anyway. So it's probably a combination, but it's not the same thing as just giving him ED treatment. So that's important. When you hear people lecturing and supporting penile rehabilitation protocols, that's not the same thing as trying to prescribe something so that they can still have that degree of physical intimacy. What's the quality of evidence to support penile rehab? It's lousy. It's a lot of junk science, okay? Small numbers, not randomized, not blinded, lack of consensus, right? We talk about a number of neurotrophic agents, what we could use down the road, perhaps encourage production of. PDE5 inhibitors appear to be most promising, and there's a value in induction of nitric oxide synthase to protect from some of these detrimental changes. It's been shown to reduce cardiac necrosis in an animal model of ischemia and reperfusion. So for the small percentage of those undergoing non-nerve-sparing radical prostatectomy, the benefits were still seen. And the speculation was that non-neuronal stimulation of nitric oxide production via endothelial nitric oxide synthase was of value, right? And there's a lot of data in the animal models suggesting, yeah, this makes sense. But clinically, it hasn't really panned out, and that's unfortunate. So if you remember this classic Seinfeld episode, right? So she walks in on George. George is saying, oh, it's not normally this small, it's shrinkage. And so, but men talk about loss of length, right? And so one study found that 71% of radical prostatectomy patients had a loss of length, a stretch penile length, anywhere from 0.5 centimeter to 4 centimeter by 3 months post-op. And half of the patients lost at least 1 centimeter, okay? Another study found that about 2/3 had shortening, and the average loss of length was about 9%. Length preservation and recovery of erectile function seem to go hand in hand. Some studies, though, have shown that this tends to recover with time, right, if you give men time to observe it. So there's a randomized study, 94 patients after a robot prostatectomy, 11-month follow-up, okay? They were standardized to receive Muse, which I never really prescribe, men tend to hate it, or Viagra nightly. At 1 month post-op, there was an average loss of 0.64 centimeters, but there seemed to be recovery by 9 months in those patients that had recovery of function. So as far as preserving length, there's been randomized to no treatment or to get Cialis at different intervals. Preop length and circumference were measured both in the flaccid and then when the stimulated erection, and there was no significant difference between groups in their potency, but tadalafil did seem to preserve length, so maybe some benefit there. So after 5 days of daily Cialis, you get steady state on the 5 milligrams, and that's half of the peak concentration you get on the on-demand 20. And the data's mixed regarding if one type of prescribing is better than another. Patients with intermediate risk of ED are shown to have better recovery with daily usage. Intracavernosal injections, these were part of the reason why penile rehab became so popular based on Montorsi's data. But they found that it may possibly encourage an earlier return to spontaneous erection, but again, small numbers in that study. Adding sildenafil in addition seems to lessen the penile discomfort. Not quite sure why that would be. So intracavernosal injections have been around since '83. Okay, you have single agent and you have multiple agents. I find that trimix tends to be one of the most common that's given out in practice, right? It's a little bit cheaper. Stable for 6 months at frozen, 1 month if refrigerated, and 3 weeks at room temperature. And it offers less pain than the alprostadil, which is PGE1, given by itself. That's your Edex and Caverject, and that's what causes the burning, right? So the papaverin, which is included within trimix, the vasodilator, that's what causes fibrosis, right? So papaverin causes fibrosis. Phentolamine is an alpha blocker. So again, I mentioned Montorsi's data. This goes back to '97, and this was what really started this wave of considering men for intracavernosal injections after nerve-sparing prostatectomy, and there was a significant difference in the spontaneous erection rate, but there were only 12 patients, no long-term follow-up, and nobody has duplicated this data. John Mulhall, 2005, said it seemed to help, but it was retrospective and non-randomized. Another study looking at Larry Levine's group, 2008, multi-center, 4 weeks post-op. They got 36 weeks of nightly Viagra or placebo and 8-week washout. And then they looked at nocturnal penile tumescence testing, which I told you we don't even really do so much anymore. It was stopped early for a presumed lack of efficacy, but the percentages looked pretty different to me. So it suggested that maybe there's a window of opportunity. But again, no conclusive data on that. There was another multi-center trial called Reinvent. So about 2 weeks after surgery, patients were randomized to one of 3 groups for 9 months. They got Levitra nightly, and placebo on demand. They got flex dose where they could titrate, or they got nightly placebo with placebo on demand, and then they had a washout. And on-demand therapy appeared to work better than nightly, but all the benefits were gone after the washout period. So the question is, have you helped them recover, or were you just helping them when you're giving them the medication? It doesn't look like you've helped their overall recovery. So as I mentioned, the function's changing with time, so it's a moving target. You have social and psychological components, right? So when a guy is dealing with certain things, whether it's his cancer diagnosis, whether it's his urinary control, whether it's his erectile function, this is all affecting his psychological state, and that can wreak havoc on his sexual well-being. It's the importance of a partner, especially when you're criticizing, we'll say critiquing data in the literature. How many of these men had a partner? How many of them had the opportunity to be sexually active, right? How strong is the relationship? Do they have a good adjustment? And there's a high dropout rate in a lot of these penile rehab studies, up to 73%. So again, the data's not quite there. So, the waiting game. Some data suggested function may improve 2 to 4 years after surgery. However, after 2 years, many suggest that patients could be considered for a penile implant if they failed all these other conservative forms of therapy. So the vacuum device seems to have benefit in an animal model looking at changes in the tissue, okay? It does increase the ratio of smooth muscle to collagen, seems to reduce apoptosis. So I tell people if they're going to use it to do it without the constriction band. Toby Kohler showed that early use prevented a loss of length. But remember, they're not just stretching the corporal bodies, right? The glans is being stretched, which is contiguous with the urethra and is not part of that tissue. But it's well tolerated if you're not using the ring. Once they own it, they own it. They don't need a prescription anymore. There's no systemic side effects. It gets them involved in recovery. So maybe there's some psychological benefits there. Muse, again, seems to work regardless of whether or not it was a nerve-sparing operation. One study showed it increased the rate of subsequent natural erections. That might have been Craig Zipp's group. That's the only guy I've ever heard lecture about Muse when I was a resident. He was the only guy that ever traveled and said you should use this. Gene therapy, we've looked at this in my lab at Wake. It's promising, but certainly not ready for prime time. Tissue engineering, Hunter Wessels was able to place autologous endothelial cells into the corpora and show that they could remain viable. Again, an animal model. My boss, Tony Atala, was able to use matrices with human cells, and we can now grow patient-specific corpora, and we should be going live with an engineered corporal study within the next 12 months. We're already FDA approved for engineered urethras, funded by the Department of Defense and approved by the FDA. So, what are my 2 cents? Well, waiting to see if patients maintain potency without helping them could be detrimental, okay? And regardless if early postoperative erect aids improve subsequent spontaneous erections, early use may help avoid post-op depression. So what are the recommendations that are out there? Well, discuss it pre-op, use a validated instrument. There's no evidence that says you should pick one particular technique. Favorable predictors, the patients are younger, they have good function before, and they have bilateral nerve sparing. But talk to the patients about the pathophysiology. It seems odd to do that, but I think it alleviates some of their concerns. Recovery can take years, and there's conflicting data on the value of penile rehab. Men having radical prostatectomy are also at risk for decreased libido, change in orgasm. Surprisingly, I see guys that come to me that didn't know that they weren't going to ejaculate anymore. So, should you throw the kitchen sink therapy at them? Some people suggest you should. Mulhall, who's over at Sloan Kettering, sees a lot of these patients who's the guy? Eastham, who's a great surgeon, right? They have a high volume practice. So they do pre-op counseling and do low-dose phosphodiesterase inhibitors for a couple weeks afterwards. Catheter removal every other night, max dose once per week. And if they're responding, they go to low dose and then high dose. If they're not responding, they're doing injections. It's a very complicated regimen, right? I don't know that's practical for everybody in practice. My program, assess their shim score beforehand. So I'll tell you there's value if you work with guys that don't do prostatectomy and you establish an ED diagnosis and use it as a separate diagnosis in the 90-day global after your prostatectomy. Because if they're seeing them for penile rehab and the billing diagnosis is ED, that's not the cancer diagnosis, and they can use their 2-4 modifier on that. Encourage them to bring their partner. Vacuum device is reasonable. Nightly doses of drugs are reasonable. Try to encourage some stimulation, getting them involved with their partner. I think it's good for the relationship. If they have even mild stress incontinence, consider some type of active treatment, maybe pelvic floor PT. All right, back to our 2 questions. Accessory pudendal arteries are the major inflow, not sole, the major inflow to the penis in what percentage of men? 10, 30, 50, 70, or 90? 70 is correct. Nice job. Which of the following agents is responsible for the fibrosis caused from intracavernosal injections? Yep, 100%. Fantastic. In conclusion, stress incontinence threatens quality of life. Surgical trends appear to be changing, and radiation is not such a great thing for surgical recovery. Despite robust animal and in vitro data, there's still not enough great evidence to make penile rehab the standard of care. It's not significantly harmful, but there is cost associated with this, and more research is needed. Thank you very much.